study the three of the contents like lower limb, upper limb and the thorax as well with equally importance, including this like embryology and developmental embryology if it is covered. We have kept this genetics out of it this time, we did not include that. So, next exam will include the genetics because the gross anatomy content is high. And so, this is the last lecture for this, and we just like started with this knee joint. I wanted to continue this particular knee joint because one of the important joint that for our life as well we will be seeing this particular knee injuries or issues related to the knee joint in our life. For yourself you will be seeing that, and neighbors, family members, etc., etc. So, it is kind of like an essential thing that you should have about knowledge on this particular knee joint. The initial basic part of this particular knee joint discussions we already have covered, like we have talked about this particular formations like the bony formations, articulation that we say, and the movement which is present in this we call them as flexion extensions, and these are the two parts which is coming into this part of this joint. And we talked about this particular joint relatively unstable as because this particular joint is sitting on two particular joints, and there is a like the ligaments which are present, there are number of ligaments are there, but because this particular joint is highly mobile and in a middle positions of this particular joint which is there, which is leading to this particular joint vulnerable for injuries despite it has all the coverings. So, this particular joint have got muscles around, we have these thigh muscles, leg muscles which is holding this particular joint together, giving the strength to this particular joint, and again to that we have this particular joint capsule deep to that, and then we have the ligaments and classified the ligaments based on this. There are ligaments which is present outside to it, we call them as extracapsular ligaments, which you have learned. This particular extracapsular ligaments are a couple of them which is known as patellar ligament, lateral and medial collateral ligament, also known as fibula collateral, medial collaterals, and on the back side it is relatively weak compared to the front side because we have this particular tendon slipping out of it, we call them as popliteus. We have this popliteus muscle which is making this particular joint capsule weaker. To reinforce that region we have a number of this patchwork there which is in form of ligament there, we call them as oblique popliteal ligament and the arcuate popliteal ligament. So, they are covering this, and in the front we have a strong ligament, we call them as patellar ligament, which is an extension of this quadriceps muscle tendon or tendon of the quadriceps. So, this far we have covered about extracapsular. The ligaments of the knee joint itself is a question like extracapsular. Now, we are going to talk about interesting part of it like intracapsular or extrasynovial intercapsular ligament. So, this particular ligaments that we have to talk about, fibula collateral ligament amongst this particular two collateral ligament is the strongest one, less prone to have injuries despite it is a thin band like this. Compared to this thicker one, we have this medial collateral ligament which is quite thicker compared to this one, which is more prone to have injuries to it, and as because this particular medial collateral ligament which is more prone to have injuries, this medial collateral ligament is attached to this particular disc which is present within this joint, we call them as meniscus. So, resulting in if we have a damage on this medial collateral ligament which most commonly happens, this menisci is also damaged. So, we get this particular ligament injuries, we get a free injury to the menisci which is make this particular menisci more prone to have injuries. So, the medial side of this particular joint injuries in the knee joint is quite common. Now, other than this we have this particular thing which we talked about. Now, straightway going to this particular ligament, this is a ligament of importance, we call them as cruciate ligament, which this ligament is present inside the capsule. That means it is outside, we have talked about this, we have the capsules of this particular knee joint, and this ligament is present within this particular joint cavities to it, which is known as cruciate ligament. So, it is intracapsular extrasynovial. This is a catch that we have to keep in mind always. So, this particular cruciate ligament, they are crossing each other, that is why they call them as cruciate. There are two of them, we call them as anterior, other one is posterior. Anterior and posterior is based on how they are anchored on this particular tibia. So, if you look in this particular tibia, so this particular tibia if you are seeing it, this is what you are seeing that from the top side or above. Now, this is patellar ligament or ligamentum patelli. So, that makes this particular side is anterior one and this is a posterior one. So, this particular ligament that you are seeing cut through here is we call them as anterior cruciate ligament. So, this is inside the capsule, but outside the synovial membrane. So, this particular thin band cord like ligament which is present in here, present in this particular intercondylar area. So, this region we call them as intercondylar area. So, how these particular ligaments are placed in this particular intercondylar area, we call them as anterior or posterior. So, they are, this is the anterior part of the intercondylar area because this is the anterior side, this is the like a patella which is present on over here and removed here. So, this is the anterior side, and this ligament on top of this particular tibia, it is anchored on the anterior side. That is why we call them as anterior cruciate ligament. Compared to that, this is a posterior side anchorage. That is why that makes this particular ligament on posterior cruciate ligament. So, anterior and posterior nomenclature, how they are named, that you have to keep these things in mind. So, it should not have any cloudiness how these particular ligaments are going back and forth, that is not the reason. Anterior and posterior, we name it because how this particular ligament are placed or pasted on top of this particular tibial intercondylar area. So, taking one ligament at a time, anterior cruciate ligament as you seeing here present in the anterior part of the intercondylar area, and this particular thing is going laterally backwards and going to this particular anterior part from this intercondylar area to the posterior part of the medial surface of the lateral condyle of the femur. So, it is going high up back side and laterally and anchoring on the medial side of this particular bulbous or swollen the femur condyles, and on the femur condyle moving to the back side. So, this particular anterior cruciate ligament, how they are placed on this anterior intercondylar area, where exactly and where exactly they are anchored to this particular condyle of the femur, that is what you have to mention. Similar to it, posterior condylar or posterior cruciate ligament, in short we call them as ACL and PCL. So, this particular posterior cruciate ligament which is anchored on the posterior part of the tibial intercondylar area, that is what you are seeing here, this cartilage. Now, it is moving anteriorly and going medially. So, this particular ligament which is present on this particular posterior part of the intercondylar area and moving forward and moving toward the medial side of the condyle and anchoring on the anterior part of it. So, how they are going and how in the back and the forth directions, that what you have to keep in mind. So, these particular piece of information that you have to keep in mind, because ACL and a PCL or cruciate ligaments are the short notes. So, we do not want you to write an essay on it, we just like mention about what this particular ligament is that. So, exact locations of the ligament that you have to keep in mind. The thing is that what we want to hear that the positions of this particular ligament in respect to this capsule. So, it is intracapsular extracsynovial ligament band like structure which is present on the knee joint holding this knee joint. There are two of them, anterior and posterior, and then their directions of it, that is it. This is the first thing that you have to mention about it. Then if you can put a schematic diagram like this, it is good enough, rather very good. Then we have to just like know little bit about the actions of it. So, there are functions of this particular cruciate ligament. We can say that this holds this particular knee joint. So, the movements of the knee joint whenever it is making, so it is checking the movements of the knee joint during flexions and the extensions, like knee joint whenever it is bending and unbending, during that part it is not slipping over because of this cruciate ligament they are placed into it. So, this particular anterior cruciate ligament, the prime function is that it prevents the hyperextension. So, whenever we are unfolding the knee joint, that means we are extending the knee joint. So, that particular extending of the knee joint is checked by this ACL, that is a prime thing. Opposite to it, this particular posterior cruciate ligament. So, whenever you are bending this knee joint, so we are folding it. So, this fold of the knee joint is checked by or prevented by this PCL. These are the two things easy to remember about this ACL function and PCL function, clear. Other than this, they have the number of functions, like they hold this particular knee joint, they helps in rotation or prevents the dislocation or sliding of the tibia and fibula, etc., etc. But to be very honest, during examination we having this much of information of whole anatomy thing, we cannot vividly remember each and everything. So, basic thing about this particular ACL and PCL is that one prevents this particular hyperextension and one prevents this hyperflexion, that we have to easy to keep in mind regard to the actions of it. So, ACL and the PCL, that particular information that you have to keep these things in mind. Now, their blood supply which is present within this particular knee joint, they are coming through the arteries, we call them as genicular branches or genicular arteries, which are supplying to this particular knee joint and supplying this ACL and the PCLs, they are supplying to it. But the blood supply is not that very great that we find a dedicated branch for it. So, it is having a scanty blood supply, that makes this particular ligament prone to have injuries. If it is there, if you have tear on these particular ligaments, they are very difficult to heal naturally unless you go for surgeries. So, these cruciate ligaments are prone to have injuries. These particular cruciate ligaments are kind of holding this particular knee joint when you are bending or unbending. That means, whenever you are making and walk in the flat surface, this particular ligaments does not have any significant role, or we do not appreciate this. When you are walking downhill or climbing uphill, this flexion and extension makes a delicate adjustment. During that time, if you have injuries on the ACL and the PCL, we have a number of issues in walking downhill and moving uphill. So, that is the thing that you have to keep in mind whenever things. So, why I am saying this? There are a number of the patients will be coming to you with this particular injuries to the knee joint, and many of them will have tear or partial or complete on this ACL and PCL. So, they will be coming with you with the asking for a suggestions what they want to do. If they are a sports person, we have to repair it, we do not have any other choices. If they are a normal living person, they are walking on a plain land. So, if they are walking in this particular region, we do not have a great difficulties if they are walking normally, unless they are running or jumping, doing anything, any extra walks. With the tear or injuries to the ACL and PCL, if they are careful. But if they are from the like a uphill persons, if they are from these particular hilly regions, they have to walk down or climb up. That persons are going to face a gross difficulty if they have these injuries to the ACL and PCL. So, on those persons, this particular repair of this particular ACL and PCL, despite that they are living a sedentary or normal life, is a must. So, that advice you should have a proper idea about, and why you are explaining that thing, that also follows with your logic to it. So, ACL and PCL, out of these two, as I mentioned, there are two ligaments are there. We have to know which are more prone to have injuries. The anterior cruciate ligament and the posterior cruciate ligament, out of these two, ACL is more prone to have injuries. So, more prone to injuries is ACL, and if you have injuries to the ACL, walking downhill, whenever you are going on the slopy downhill regions, it has difficulties. Okay? So, this is what you have to keep in mind regard to this ACL, PCL and injuries to it, and the consequence of the injuries to ACL and PCL. So, this is things together which is placed in what is ACL, what is PCL. Do not just like have to remember a great deal of knowledge, you just have to remember what they are, where their positions, how they are anchored, and what are the basically functions or functions on each of these particular tendons, what ligaments, how they are making, and which are having more prone to have injury for the clinical interest. Now, if they have injuries to it, we do check for it, just like in the hip joint we tested like a tendon bar test, right. So, similar to that we have to test this particular ACL and PCL, which one is damaged. So, to that particular do the clinical examination, we do a clinical examination on the knee joint, we call them as drawer test. So, what do you mean by the drawer test? Just like we have a chestnut drawer, like we pull this particular drawer hand chest out and put it down. So, this particular examination of the knee joint is just like pulling out and pushing back. So, we ask this particular patient to just have this particular knee joint folded like this, resting on a flat surface, and then we lift this particular knee, lift this particular foot, and just make this particular weight of this particular leg is resting on this examiner's hand. Now, this particular leg is handing free and with the weight is on your hands, then this particular thing becomes lightweight. So, once it lightweight is there, we just like pull this particular knee or this particular leg forward. So, this is what we are just trying to see whether you can pull the drawer or not. If it is too loose, if it is coming too easily, that means we have a subluxations or injuries or tear of this particular ACL. We call them as anterior drawer test positive. If you have too easy thing, if it is coming too easy, it looks like the knee joint is moving anteriorly too far. So, we call them as anterior drawer test. To test this ACL, if you are going to test this PCL, you have to do this opposite to it. We call them as posterior drawer test. The same thing, you are pushing it down. So, if you are pushing the drawer close, so then we call them as posterior cruciate ligament test, and if it is going too far, if it is moving too backwards easily, then we call them as posterior drawer test positive. That means we have a subluxation injuries tear to the PCL. Alright. So, this thing we do this ACL and PCL, the detail of the process of the clinical examination you do not have to know, just have to know this drawer test name. So, drawer test, anterior drawer test and posterior drawer test for testing this ACL and the PCL integrity, that is it. So, do not jump into how we are doing to do this process, just remember this particular test, name of it and what you are testing on it. Just like for example, if you hammer this particular patellar tendon, so it creates a knee jar. So, what muscle you are testing? We are testing this quadriceps muscle, right. So, just like that. So, we are testing this particular tendon or this ligament, sorry, of this particular like ACL and PCL. To test that, we do the clinical examination, we call them as drawer test, anterior drawer test, posterior drawer test, that is it. Now, coming from this particular ACL and PCL, we have to go into some other factors which is related to the knee joint. This is another point which is very important, just like ACL and PCL. We call this as a meniscus. We have a intrigue or in place architecture of this fibrocartilage disc within this knee joint. We call them as menisci. And we know that this particular knee joint has two parts, medial side and lateral side. Likewise, we have this particular disc which is present in between this right side and left side of this knee joint, placed in between this femur and this particular tibia. We call them as meniscus or menisci, depending on singular or plural. So, they are fibrocartilaginous disc, they are separable. So, this particular disc are two in number, one is on the medial side, one is on the lateral side. We call them as medial and lateral meniscus or menisci. So, this medial one and the lateral one have got little bit shape difference. If you just have a look into it, this particular fibrocartilaginous disc are having two different shapes. This particular disc which you are seeing here is this lateral one, this is the medial one which you are seeing here. This lateral one is nearly circular and this medial one is more or less half of a moon or sickle shaped. So, this is nearly closing thing. So, 3/4 part is closed over here. So, you can call it circular one. This one we call them as like a half of a moon or semicircular one. If you look in the surface of it, it has two surfaces. One is superior surface, this is facing this femur and it is anchored on the tibia which is known as the under surface or the lower surface. It has two margins like outer margin which is thicker and inner margin which is thinner. So, there are two margins like this, inner margin, outer margins like this. It has two ends, one is anterior end, one is posterior end. So, this is the tibial ligament and patellar side. So, this is anterior side, this is posterior side, and anterior and posterior side we have a little bit expansions, we call them as horns. So, it has an anterior horn and posterior horns on each of them, this particular menisci has. So, this is about the description of it. Whenever you are seeing this, it is kind of what it is, it is a cartilage disc. What kind of cartilage we have? We have three different types of cartilage in our body, fibrocartilage, elastin cartilage and hyaline cartilage. So, this one is made of fibrocartilage disc. How do the disc look like? The medial one, two of them are dissimilar. One is half of a moon or semilunar shaped and other one is nearly circular. Where they are placed? They are placed on these condyles of the tibia or superior surface of the condyle of tibia, say are on the medial side and lateral side. They have its shape which is present on it and it has parts, two borders, two surfaces and two ends and two horns are there, projections are there. What are the functions of this particular disc are there? So, this particular disc which is present, they increase the congruency or this particular depth of this particular joint is increased. So, that this fitting of this femur on the tibia is there very well. So, this particular femur and the tibia, they are whenever they are making this particular knee joint movement, they are moving like a single unit or just like a moving very well. So, this particular cavity of these things are kept in here. They keep this particular joint as a shock absorber. So, whenever you are jumping, thumping or doing these things, so these vibrations and this particular pressure are kind of like a transmitted or absorbed. So, they are kind of shock absorber to us. Then they are holding some kind of fluid in here. So, synovial fluids which are present inside, they keep inside by this particular these ligaments which are present in it. Lubrication part is concerned. Along with that, they are innervated some kind of nerves, so they carry the joint position sense. So, if you close the eyes, we can still understand what are the positions of our joint. We call them as proprioception. That means, closed eye we can see that the joint is folded or unfolded. So, this sensation of understanding the joint position sense or the feeling of the joint, we call them as proprioceptions or joint feeling sense. So, these things are coming from these particular nerves which are innervating or wearing these particular regions, and they give a sense of this particular joint position, and they adds to the protections etc., and weight transmissions to this. So, these are the things about this particular knee joint menisci that you have to keep in mind related to the basic understanding of it with a schematic pictures like this. So, menisci, medial, lateral, which are there. Now, coming to the other part of it, other than this particular menisci, they are present in this particular region. So, this menisci splits this particular knee joint into two tier, like ground tier and the first floor. So, this particular knee joint can be divided into two parts. So, one part is from the menisci to this femur. So, we call them as meniscofemoral division, and other part is menisci to this tibia, we call them as meniscotibial division. So, if you are just like going to learn the detailed movement of this particular knee joint later on, or if you are just like following the kinesiology or joint movement science, then we have to just like understand this particular joint cavity split, like how this upper tier of the joint is working, how this lower tier of the joint is working. Then you will see that this menisci splits this particular knee joint into two parts, upper part and the lower part. But again, these divisions of the knee joint cavity is not that very greatly important for us at the undergraduate level. So, we have to understand these meniscus positions, how do they look like and what are the functions of it. Now, coming to this particular blood supply to this meniscus, this menisci do not have, just like this cruciate ligament, do not have any dedicated blood supply to it. We have some kind of genicular artery which is supplying the knee joint, they are pouring into this particular joint, and within this particular joint or this particular joint cavity or the synovial fluid, they are lubricating it and putting this particular menisci alive by diffusions method. So, they are getting the nutritions or getting the oxygens or getting the nutrients, whatever things are there, they are going through diffusions. So, they do not have the dedicated blood supply to it. What does it mean? So, if by any chance our menisci, if it is tear or damaged, we have a very greatly reduced chance of recovery. So, we are not going to regenerate it. So, if we have injury to the muscles, if it is muscle is wasting, we can just like do an exercise and regenerate it, because we have plenty of blood supply to pouring in it. But if you have an injury which is occurred to this fibrocartilage disc, we do not have a great chance of healing it back or regaining it back. So, if it is tear, if it is damaged, it is going to be there, right. So, this menisci, as I am saying, they are shock absorbers. If you are just like doing a very overzealous work, they are going to be damaged. So, we have to have a careful understanding on how to save this particular menisci. So, this particular menisci, they are present over there. If you are pressing too hard, this femur is pressing too hard on this particular tibia, by any chance, by any movements, there are chances of injuries to it. Which are the person they are prone to have this too much pressing on it? Soccer players. So, they are using this knee joint like anything, they are throwing this particular knee joint at any directions at any point with the enormous pace. They are striking the ball, they are challenging the individuals. So, rugby players or body soccer players, they are also having this prone to have injuries to it. So, once this particular knee joint menisci are damaged, as we have understand, they are relatively avascular. So, chances of recovering it back to the normalcy is very less. So, this menisci undergoes some kind of injuries, we call them as tear or injuries which is related to this particular tear, we call them as transverse tears. If you are splitting this particular one like this, which is like a minor injuries, I would say, and if they are going on this tear like looks like a handle of a bucket, we call them as bucket handle tear, which is a very grave thing. If you have chipped things out there, this will be chipped out. So, bucket handle injury or the transverse injury, they are having this particular injuries involving this particular meniscus. Now, again we learned about ligaments in the medial side, medial collateral ligament, lateral collateral. Learned about ACL and a PCL. Out of that we singled out which one is more prone to have injuries. Likewise this particular meniscus, two of them are also having a chances of these injuries, one of is more than that of others. So, this medial one is more prone to have injuries, despite this particular lateral one is bearing the more weight. Why? This middle menisci which is present on here, we have mentioned that the middle meniscus is plastered with the medial collateral ligament. Remember that we said that medial collateral ligament is basically anchored to this particular medial outer side of this particular medial meniscus. So, as a result of that, medial collateral ligament, if it is damaged, this particular medial meniscus is also going to have damage. So, the medial collateral ligament damage is kind of like a very common, so is the medial meniscus, resulting because they are together, they are inseparable. So, one thing is taking a blow, the other one is also taking a blow. So, out of these two menisci, medial one is more prone to have injuries. So, explain why the medial menisci, or out of these two, which one is more prone to have injuries and why. This is one reason why this is there. Now, this is one thing why this particular medial menisci is more prone to have injuries. Second thing is that how the lateral menisci is escaping the injuries. Now, the lateral collateral ligament, lateral menisci is bearing the more weight than that of medial one. So, when you are standing, this lateral part of this particular body is bearing more weight. So, it is taking more load, but still it is escaping these injuries. How? This between this particular lateral menisci and this particular collateral ligament, which is lateral collateral ligament, we have a tendon of popliteus popping out. So, this particular popliteus muscle is present in between these two. So, resulting in whenever this folding and unfolding is knee joint is going on, contractions of the popliteus makes this particular lateral menisci go in deep, so that it can escape these particular injuries. So, these particular positions of this particular position of this popliteus, which basically saves this particular lateral collateral ligament injury, and so this particular lateral meniscus from it. So, this popliteus muscle tendon, which is slipping in between these two, is saving this particular lateral one, and medial one is more exposed to it because it is fixed to this particular collateral ligament, and collateral ligament is damaged more often, and so is this particular medial menisci is having more chances of injury. So, this is a kind of like a very common clinical problems that we face it. In case of this knee joint, this injury to the collateral ligaments are common, injuries to the cruciate ligament is common, and injuries to this menisci are common. So, they are coming for your examination in each and every part. Why they are coming in your examination? Because they are going to show up in your clinic, they are going to show up in your life with these injuries, and you treat it accordingly. So, we want to be prepared for these injuries or these issues which are more commoner. So, that is why you have to focus on the anatomy of this particular knee joint, involving these particular ligaments, involving this menisci, and involving to the injuries to it which is related to it. So, this is what we have to keep in mind regard to this particular meniscal injury and this particular thing which is related to it. Now, other thing about the clinical presentation. Now, what happens, this particular menisci injury or this particular ACL injuries or PCL injuries, they are not like very abrupt, like the moment you get the injuries, the patient is not feeling the pain or not immediately feeling the impact. Why? Because the innervations on this particular region is also relatively weak. So, the moment the individual gets this particular pain or injuries, they do not realize they have the injuries, or they ignore if they are not trained well. So, what happened in the 60s and 70s in our areas, we have a very poor understanding on this particular anatomy of the knee joint, and so this particular sports trainer as well, and so also the players as well. So, they ignored it, the injuries they have during this time, and many a times we see these football or soccer players lost their life because of ignoring these particular minor problems. So, whenever they feel it like we have something going with the knee joint not well, they should stop it. Stop means stop at that very moment. So, you see that if you follow these particular soccer leagues like EPL or La Liga or anywhere, you will see that the moment they feel like they are not walking well, they stop it and raise hand and go out. Even it looks like it is not a big problem apparently. In India, once they get a stretcher, then they go out. So, they carry on till they just like get a chance like to continue the game. So, this is the difference that makes this particular thing. If they stop at the moment time, they may be just like after a rehab of 4 weeks, they may be getting back. And in India players, they keep on pushing hard and once they finish the game, they never come back. They lose this particular whole of the career. So, thing is that these injuries to this menisci, whenever they are starting with, they are asymptomatic or less symptomatic. Next day, when they wake up from bed, the knee will be swollen and sore and they are unable to move it, because they ignored that time. The swelling was not there, pain was not there, but it came after some time. So, fluid and everything, stiffness gets on as the time progresses. So, keep this particular thing as well in mind. If you have an injury patients with the knee joints, they show up late with these symptoms of it. Before that, the patient will say, na kichu hoy nahi ho, I am good, अच्छे हैं, कर लेंगे. बाद में देख कुछ नहीं है, छोटा सा खरोच है, ठीक हो जाए. We are all superhuman kind of attitude as there. So, you have to keep these things in mind, meniscal injuries and related to this. Other thing which is also coming here outside the knee joint. So, outside the knee joint we have a number of cushions, we call them as bursa. In the shoulder joint we have learned that. There are numbers of bursa, they are placed in here. We call them as pre-patellar bursa in front of this. We have this bursa, we call them as infrapatellar bursa. And we have the bursa, we call them as suprapatellar bursa. We have a bursa, we call them as popliteal bursa. We have a bursa, anseris bursa. So, there are number of the bursas are there. They are cushioned or air or fluid filled cushion packs between these tendons or the friction points between the tendons on the joints. So, these particular bursas are relatively subcutaneous and they are prone to have frictions. If they are, we are frequently making a frictions on the skins of it, and these particular bursas may get irritated. So, then we call them as bursitis. So, these bursitis are common in case of the prepatellar bursa and infrapatellar bursa, which is lying under the patella and front of the patella. So, they are known as prepatellar bursitis and infrapatellar bursitis, which are common problems. So, you have this particular knee joint problems which is having for us, because we bend the knee joint like hell on doing any jobs. So, whenever we are making a frictions on the knee joints, this particular bursa like prepatellar bursa or infrapatellar bursa, they are irritated and inflamed, like fluids are started to getting accumulated in excess amount around that bursa. So, we call this as the inflammations. So, this particular inflammations is common in this bursa region. We call them as housemaid's knee or carpenter's knee, because this particular prepatellar bursa is inflamed. Similar to that, we have this particular Klegman bursa which is involving this tibial tuberosity which are pressing on this particular region and leading to this particular region which is inflamed. We call them as infrapatellar bursa. There are other types of bursa which is present there deep in the popliteal region. They are maybe having a deep to subcutaneous bursa. So, they pop up like tendon, pop up like this particular region cyst, and they going on the back side. So, this particular cyst which is arising of this particular bursa, we call them as Baker's cyst. The individual may have a Baker's cyst like this. So, they may be swollen on the back side and asymptomatic, they do not remember or recognize. What happens? This particular Baker's cyst may burst open, rupture, having infections and leading to the skin necrosis and opening the knee joint from the posterior side. And then they come to attentions like, oh, what happened? All of a sudden the knee joint has no problem, and then it is opened up ulcers and something like that. Because of this particular cyst was there, they are bursting open to this particular knee joint and making an ugly looking ulcer. Then they realize that we have something problems with it. So, anatomically, if you do not know this particular existing of this particular Baker's cyst, you may be seeing that this may be just like having a big issue like a cancers or like a big issues which is maybe happening in here. It is nothing like that. You will do the clinical examination, CT and MRI on these regions, you will get nothing, but still ulcer is there. We will be clueless why these particular ulcers are there, because these are ruptures of the Baker's cyst which is rupturing through the skin and ulceration and necrosis is there. So, these things happens because of this particular the unnoticed cyst or unnoticed expansions of this bursa, which is involving this knee joint. So, this is all about this particular regions which you have to keep in mind. Moving to this particular knee joint blood supply, they are coming from the branches of the femoral artery and the popliteal arteries. Giving the branches, we call them as genicular artery branches. They are making an anastomosis on the medial side and lateral side, and this particular anastomosis supplying the knee joint over there. Innervations of this region is coming from this all the nerves which is passing by, branches of the femoral nerve, tibial nerve, common peroneal nerve, obturator, all of them are supplying to this particular knee joint, and we have a clinical problem based on this innervations. So, I will be coming into it. Coming to the movement which I am going to talk about, then we will talk about the innervations. The movements of the knee joint are two varieties, flexions and extension, which is like 90% of the movement. And apart from that, we have a movement we call them as medial rotation, lateral rotation, which is very less. So, flexion and extension of the knee joint, which is very popular for us, which we do the clinical examination for, like folding of the knee joint, unfolding of this particular knee joint. Flexions is done by this particular muscles in the back side, hamstring muscles. Extensions is going for the front muscle like quadriceps muscle. These are the two popular movements that we have understand, flexions and extension. Other than this, we have the medial and lateral rotations, which is not very greatly appreciated, done by the semimembranosus and semitendinosus and this particular region. So, these are the two movements that we appreciate in here, flexion and extension with this medial and lateral rotations. The third variety of the movement, we call them as movement of the knee joint, is known as locking of the knee joint and unlocking of the knee joint. This is hallmark movement for the knee joint, which is only present in knee joint, and that has a great deal of advantage for it. So, this locking of knee joint and unlocking of the knee joint, that we have to understand, and we have to prepare for examination. So, take one at a time. Locking of the knee joint. What do you mean by locking of the knee joint? Stabilizing the knee joint in a positions where this particular femur and the tibia is locked in a position, and which is leading to the locking positions of this knee joint as well. So, that person or individual can stand effortlessly for a period of time, which I am doing right now. My knee joint is in locked position. What is happening over here? We have the femur condyles and the tibial condyles are in contact with each other, and in a positions where my muscles, all the leg muscles are in a tone, but they are resting. So, I am not doing any muscular exercise, despite that I am standing. So, this particular positions we call them as locking of the knee joint positions, which I am doing. So, what do you mean by the locking? So, this is a definitions of it, we have to write about it. Locking of the knee joint by definition is positioning of the femur on tibia to stabilize the knee joint to minimize the effort of the muscular actions during standing. This is the definition. How do the locking thing happens? So, this particular locking thing starts to happen during this last phase of extension of the knee joint. So, this is what is flexions of the knee joint. Now, I am extending it, right. So, this is extension I am going to. This is a last phase of extension which I am going to make this particular straight together. So, this last phase of extension we call them as last 30-degree angle closure. So, when this final thing is going on at the last stage, we have a rotation of this particular bones over here. So, we have a rotation, we see that the medial rotations of the femur, which is happening here on the last phase of extension on this particular tibia. So, what happens? This medial rotations of this particular tibia is going on. So, the tibia femur is going on tibia. So, this particular tibia is fixed. Now, this particular femur is going on in the last phase, and then at the last phase it is rotating medially. So, there is a kind of medial rotation of this particular femur on the last phase of extension, which is going on a medial direction to on top of this particular tibia. So, this particular thing which is happening, once this particular movement is achieved, we have a knee joint in locked positions, no further movement can be takes place. So, no further extension is possible, no further lateral movement is possible, no further medial movement is possible after this particular closure. That is why this knee joint we call them as locked positions. So, what mechanism is happening over here, that what you have to key in. When the foot is on ground like this, at the last phase of this extension of this knee joint, there is a medial rotations of the femur on tibia that is going on. So, normally what happens, this particular things is going in straight, but instead of going straight it is moving medially. Which one is moving medially? The femur is moving medially on this particular tibia and the last phase. Once this particular thing is there, there are no much extension is possible, no much lateral or medial movement is possible. So, this particular mechanism we call them as locking mechanism of the knee joint, and this particular movement is assisted by these contractions of the vastus medialis. So, that is what you have to keep in mind. What do you mean by this locking? The definition of it, how this particular locking is there, the rotations of this particular medial on the femur on the tibia on the last phase of extension of the knee joint. What we achieve over there, there are no further movement of the knee joint position possible in that particular region. What the utility we are getting? We are reducing the muscle effort during that particular time, and then what muscle is helping these things as vastus medialis along with this particular quadriceps, which is largely contributing to this particular locking movement. Now, once this particular locked thing position is there, if you just want to start over, then we have to unlock it, then we can walk it. So, to unlock it, we have the opposite mechanism which is happening here. So, unlocking of the knee joint, what is that definition of it? So, unlocking knee joint is that is a lateral rotations of the femur. Previously it was medial rotation. So, now the femur have to rotate to that normal positions like laterally rotate on tibia during the beginning of the flexion. So, if I am starting to work, then I have to bend this knee joint. So, the beginning of the flexion, we have these opposite rotations of the femur which happened previously on the medial side, now it is happening on the lateral side. So, lateral rotations of the femur on tibia during this beginning of the flexion, that is happening. Which of the muscle is helping this one is popliteus. So, the popliteus is a muscle which is unlocking it. By doing this particular, what we are achieving? We are achieving static position to the mobile positions. So, one movement is giving us the static posture, one movement is going us to give the mobile posture. So, the standing positions and this moving positions is on this knee joint is achieved because of the locking and unlocking of the knee joints. So, this particular phenomenon out of this particular knee joint movement is very hallmark specific. This is only present in knee joint, that is why this is very commonly been asked in examination. So, again what is locking, that you have to define. What happens over here is movement of this particular femur medial side, it is moving in which phase of this knee joint movement? At the last phase of extension. Which muscle is assisting? Is vastus medialis. Opposite to this particular locking is unlocking. When they are happening at the beginning phase of flexion, that means when you start to walk, what is happening? The opposite movement of this particular locking, that is lateral movement of this femur on tibia. What muscle is assisting to it? Popliteus. So, this is what we are having. What we are achieving with this particular locking? We are achieving a reduced muscle effort during standing posture. If we are locked in the knee positions while you are standing, what we are achieving in case of this particular unlocking? We are going to achieve this mobile phase of this knee joint. So, whenever we are going to start from the standing posture, we have to unlock it, then we can walk. So, these are the two things that we have to keep in mind. Coming from this locking and unlocking of this knee joint, this is the last thing that you have to keep in mind regard to the innervations of it. So, as I have mentioned, all the nerves which is crossing this particular hip joint is going to supply the knee joint as well. So, this particular nerve that we have seen in dissection like femoral nerve, that we have seen the sciatic nerve, that we have seen obturator nerve, that we have seen like a common fibular nerve, they saphenous nerve, they cross over this particular knee joint and go to supply to it. Now, what is the significance of it? Significance of it that if we have an issue on the knee joint, we may have a radiation of the pain to this hip joint and vice versa. If you have a pain on the hip joint, they may be radiating to this particular knee joint. So, there are a chances and a possibility of radiations of the pain between these joints, that means hip joint to this particular knee joint. So, this phenomenon we call them as radiation of pain, that means it is starting from a different zone and it is transmitted to this particular different region. So, we call them as radiating. So, if we have an issue on these sections of the class, as well will have an counter effect, we call them as collateral effect. Likewise, if we have an issue with these sections of the class, these sections will also have an effect on it. So, we call this as a collateral phenomenon, also known as radiation of pain. So, if you have a fracture on the knee joint, the patient may be experiencing pain on the knee joint as well. So, explain how the pain in the hip joint may be radiated to this knee joint, or vice versa, a pain in this menisci may be radiated to the hip joint. Explain how, explain why. So, because of this particular same nerve innervations on the hip joint and the knee joint, they are passing through, there are chances of this transmission of these pains from the hip region to this knee region, or groin region to the knee region, or knee region to the groin region on the hip joint region. So, explain why. There are a number of explain why regions are there. You have to be very meticulous on preparing this particular knee joint. From the knee joint itself, 50 mark questions may be given from any and each aspects, because they are so clinically important, so intrigue, and so many phenomena which is present involving the knee joint itself. We can give a semester exam on the knee joint, right. So, anything can possible with the knee joint. So, prepare the knee joint like hell. It is going to be there for your life, trust me. It is not about anatomy, you finish and prepare for the examination. Till you continue with this profession, knee joint problems or knee joint issues, knee joint anatomy will be there, will be coming up, will again and again. So, you are going to make a mistake or going to make a right call, depends on how we are preparing with the anatomy. If you are preparing this particular anatomy, it is not a one day job. Again and again you do just like a read, unread and reread kind of things, you have to keep on doing. So, this is all about this particular knee joint. Ligaments, the positions of the ligaments which are related to it, and the structures which is related to the parts of the knee joint, movements of the knee joint, locking and unlocking, flexion and extension, muscles involved, these particular flexion extensions, locking, unlocking, innervations of this particular knee joints is particularly important. Vascular part which is called them as anastomosis, which I am escaping because we just like do not want to complicate this. This vascular part we call them as anastomosis, genicular anastomosis itself may be a 10 mark question, because this particular anastomosis is also very clinically relevant. So, but again later on in a higher class maybe you will learn about this. I do not want to complicate these things right now. So, but this locking, unlocking or movements of the knee joint, nerve involved, radiations of the pain, prone to have injuries on the knee joint, tears on the collateral ligament, tears on the cruciate ligaments, injuries to the menisci, clinical presentations of the menisci, which one is more prone to have injuries and why, they are kind of important for us or very important for us. So, this is about this particular knee joint, covers up with the clinical problem and the gross.